this topic is about the success formula about IV insertion. Though, no, this is just a twist or a googly, I would say. Though the title says step by step of technique of IV cannulation, as a disclaimer, I'm sorry for tricking you into this. It's not about the steps of technique of IV cannulation, because that's, as we saw in the poll, all of you are pretty good at it. No, it'll be redundant for me to go and talk about the steps of IV cannulation. But what we need to know is the tips and tricks, identify the common pitfalls. What are the strategies to improve IV cannulation success rates? No, we saw that almost 50% said 90%, but the rest are still not very sure about it. And we will introduce the success framework for standardizing these practices. So, IV cannulation is very common and a very critical procedure in healthcare. It is used for medication administration, fluid therapy, nutrition support, and at any point in time, 70% of hospitalized patients receive IV therapy. So the almost two-thirds or more than two-thirds, three-quarters of patients have an IV line or IV fluids going through the veins. So it is very, very common. And this common procedure has to be done safely and has to be done in a way that we don't cause harm to the patient or anxiety to the patient. And the best way to do it is put the IV line the first time and without much pain to the patient. So what are the common pitfalls? So that we can divide it into preparation. Preparation for IV line is the most important part. Many times we just grab an IV cannula, grab the tourniquet and run to the room. But this they found in many studies, the preparation accounts to IV cannulation failure in more than 40% of cases. So not preparing the patient properly, informing the patient what you're going to do, ensuring all the equipment is there, taking it in a clean, disinfected tray, and very importantly, not using pain relief measures. Many of my colleagues say, anyway, if you get an IV also, it is going to be one prick. So why don't you just put the needle into the vein with that same needle pain? But that is not true. And if you have had the experience of an IV line on yourself, you will understand that after putting the IV line, there is a lot of pain around that site. But if you put a local anesthetic or local anesthetic cream, definitely this eliminates the pain of putting an IV cannula. The next is the actual technique, not identifying the suitable vein. And not disinfecting the gloves after repalpating. So first you should palpate the ideal vein, then you'll put a tourniquet and then wear the glove. Then suddenly, you're not very sure about the vein. And then without disinfecting the gloves, you would touch the vein, and that is another cause for phlebitis. So either disinfecting your hand and wearing disinfected gloves or a sterile glove is important before you repalpate the veins. And maintaining aseptic technique. We spoke about ANTT, antiseptic non-touch technique, in the last webinar. All those principles apply in this technique as well. And the last is the post-insertion pitfalls. So not securing the cannula. Fixing the cannula is very important, and if you don't do it, the incidence of phlebitis also goes up and the cannula may slip. Documenting the procedure adequately is another major pitfall, not documenting the procedure, sorry, and not preventing pressure injuries, especially in unconscious patient in the ICU. If you do not pad the cannula properly, then that hard part of the cannula can cause pressure injuries. So all these are common pitfalls. I have not just listed it randomly. These are based on studies from various papers which have been published in the last 10 to 15 years. I have not quoted them because for each of these, there are about 2 or 3 references. It will be filling the slide too much. So the next point we have to see is the complications. So what are the complications if you don't put in the IV cannula properly? So phlebitis is the most common. Infiltration and extravasation, if it is not, the tip of the cannula is not in the proper position or it slips away. And hemorrhage, if it is, you accidentally get into the artery or into a large vein. So there are also many patient factors you have to take into account. So this is very important. And we will see the success formula looks at each one of these things. So keep in mind in this when we talk about the patient factors. So the age of the patient is very important. So it is sort of difficult in pediatric and elderly patients. Pediatrics because the veins are small. In elderly, the veins will be already hard and thrombosed and will slip under the when you put the tip of the cannula inside. The size of the patient, not the size of the cannula. The size of the patient, no, patients who are a bit plump or have very small body size, both extremes, no, it complicates the vein access. Vein accessibility. So if there are very limited veins or unsuitable veins, these patients are classified as patients who have DIVA. DIVA is nothing but difficult IV access. So it is very important to identify these patients. We will talk about it a little bit more detail in the coming slides. Failed attempts. So if already you're starting to put an IV line and or your colleague has asked you to come, already the colleague has tried 3 or 4 times, and you are now entering the room. The history of IV failures either in the same hospitalization or previous hospitalizations is an important history to find out. If that is the case, then you should seek for expert help. Or if you are sort of already an expert and can use the ultrasound guidance, then you should straight away use it, not try to do it blindly. So diabetes causes vascular changes, which will reduce the success rates. IV drug use. If already the patient has been using medications, then there can be thrombosis, and this can cause problems. Patients who are on cancer treatment or chemotherapy, these are highly irritant drugs, and they cause thrombophlebitis, and they are also difficult IV access patients. The last is the patient anxiety. Needle phobia is a genuine condition, and if these we should be sensitive enough to recognize this. More common in children, but not uncommon in adults also. So all these are patient factors which you need to keep in mind. So we looked at the first time IV success rates. No, we actually, it will come to this average. Now, when we did the small poll in the beginning of this webinar, it sort of matches to this. Pediatric and adult success rate all over the world ranges anywhere between 65 to 86%. So it is never 90% or even 100%. So always there is a chance for improvement in the success rates. So that's the whole reason now we are doing this webinar. So the key factors. So now that we've seen the pitfalls and complications, what are the key factors for successful IV insertion? We looked into detail at the patient specific factors. So before you go near the patient, look into take the history, look into the case sheet, and understand the patient specific needs. And then proper preparation. Now we looked at the pitfalls, isn't it? Proper preparation and effective post procedure management. These are protocols which should be in place. So it is fair to say that success with IV cannulation is just not a technical skill. It goes beyond technical skill. You may be the best in the world. You may put an IV line, without, maybe anytime they wake you up in the middle of the night, or as they say, with your eyes closed. But still, you can have failures because of preparation issues or post-procedure management. So we need to have a comprehensive, structured plan for maintaining the IV. So how do we improve the IV cannulation success rates? So there's no doubt ultrasound guidance enhances success rates. And we can also use vein visualization devices. These are infrared lamps and other devices which will sort of light up the skin, and you can actually see the veins much better. So these are much cheaper than ultrasound machine, and also as because of a country we have strict PCP and DT rules. It is not possible for us to have the ultrasound in each and every ward. So these vein visualization devices are very useful because you're able to visualize the veins and are much cheaper. Simulation-based training is no sort of alternative to that. If you can have a arm mannequin and keep training your juniors who just joined you in simulation-based training, it improves the healthcare worker skills and thereby the insertion rate. Standardized protocols minimizes errors, and we are going to talk today about the success framework. Topical vasodilators, giving nitroglycerin ointment and all that. Mixed views about this. Some studies say okay, some studies say not that good. So I wouldn't recommend that. And continuous education. I think simulation-based training and continuous education are side by side. So these are very important. And this particular webinar is also should be combined if whenever you do an IV cannulation technique workshop, because this what you do with IV cannula is also important than just the technique, as we already saw that. Patient positioning, vein selection, proper lighting, all these things are also important and improves the insertion rates. Now, as promised, we will explore the success framework and how it can enhance the IV cannulation practices. So, success is an acronym. SUCCESS. It's not actually an ideal word for an acronym. It has got two C's and two S, and many of us are confused with the spelling of success. I always use my spell checker when I write success, but this is what it is. It is a recognized acronym. So let us all remember the spelling of this word before we use the acronym. So S stands for skill and selection. U is understand and prepare, understanding the patient needs. We already dealt with that in detail. And prepare. C is patient's consent. The other C is to clean the site for asepsis. E is when do you escalate? Escalate meaning when do you accept defeat and ask someone else to come to your help. So that is escalation, going to a higher level of help. And S is secure after the putting the IV cannula, that is the fixation of the cannula, and finally signing and documentation. So that is in short the success. So we'll look at each one of these in a little bit of detail. So stands for skills and selection. Be honest with yourself. Are you skilled? If you're not, and or if the patient, you recognize the patient as a difficult IV access problem, DIVA problem, get help straight away. Don't try to poke the patient several times and cause pain to the patient. And ask yourself, what is the intended use and what is the duration and type of therapy? Do I need to put a peripheral line or central line? So all this is before you actually decide to put an IV line. So asking yourself whether you have the skill, what is the intended use? Is it just for IV line? Am I going to give medication? Or is it to put a TPN? Or is it for a long-term use? All these things have to be thought about first. Then is the selection of the IV catheter. So PVC stands for peripheral venous catheter, the IV cannula which we usually use. The midline catheters, we don't use, most hospitals don't use this. These are slightly longer catheters used peripherally. It's about 10 centimeters or up to 15 centimeters long. If you put in the basilic vein, the tip may go up to the axilla. These could be used because there's less chance of extravasation and infiltration, but should be used only when you are using it for clear or non-irritant or normo or osmolar solution. And whenever the duration of therapy is less than 7 days. So let's forget about midline. So peripheral venous catheter is for clear, non-irritant, normal osmolarity solutions like normal saline, Ringal lactate, and if the duration of treatment is less than 7 days. You could use a PICC line, that is peripherally inserted central line, where the tip of the catheter will go into the superior vena cava. So this requires to be either confirmed by an X-ray or using an ultrasound. And this, once it is confirmed, the PICC line can be used for irritant, that is the chemotherapy agents, or hyperosmolar like 3% normal saline, similar hyperosmolar solution, or the duration of therapy is greater than 7 days. So that is about the S, the skill and selection. Second is U, understand and prepare. So what is that you have to understand? Understand the condition of the patient. I spoke in detail about this, the age of the patient, pediatric or geriatric, size of the veins, Is the vein accessible? Is there history of failed attempts, diabetes, IV drug use, cancer treatment? All this we looked into detail. So consider these. Location. So studies have shown the best vein to use is the basilic vein. It is usually in the forearm. It is straight. It usually doesn't have much of tributaries. So this is the most preferred vein. And in many patients, you look at the condition of the veins. Is it easily visible? Is it palpable or is it thrombosed? And very important, before putting an IV line, ask yourself, is an IV line really necessary? All said and done, it has its own pitfalls and complications. Can we give the patient oral medication? Many times there is a misconception that IV and medications are better than oral medication. It may not be true. The bioavailability will be the same between oral and IV therapy. So this is something to consider. Do you need pain relief? Use topical anesthetic. And do you have all the equipment and the environment is all set, lighting, patient position? And if at all you're doing in a pediatric patient or somebody who's very anxious, do you have patient and staff support? So that's about you. So the next is, I just wanted to talk to you about local anesthesia. It's very, very easy to do it, especially in children. We have a solution. I'm sorry to mention the trade name here, but people are familiar with this. There are other brands available. So it's a mixture of lidocaine and prilocaine. So you spread it thoroughly and you select the vein, put a sort of rectangle around it, spread it thoroughly, and apply one of those dressings, transparent dressings, which will keep it in place. Leave it for about 45 minutes to 1 hour. It will completely anesthetize the skin. And it is, I feel, compulsory to do it in children. And many adults also would at least give them the choice. Do you want a local anesthetic? Don't just not give this choice to the patient. So that's about understanding. SU, then the C is consent. So verbal consent, you don't need to have a written consent for IV cannulation. You got to tell them this is the procedure I'm doing, and there will be a little bit of pain when I put it, and how long it's going to be, what is its purpose. Explain clearly, and also as you're doing the procedure, warn them in advance what you're going to do next. For example, you should say, I'm going to feel for the vein. I'm going to put the tourniquet. I'm now palpating the vein. Now I'm cleaning it with an antiseptic solution to disinfect the skin. As you're doing it, explain it to the patient. That relieves the anxiety. Just a few seconds before you do it, you should tell the patient, it relieves the anxiety to a large extent. So do that in a very systematic and phased manner. So the first C is, I'm sorry, the second C is, so the first C is consent. The second C is clean the site. So you clean it with alcohol swab or 2% chlorhexidine solution. Very important is to allow these alcohol or chlorhexidine to dry. Otherwise, the disinfectant action doesn't take place. So you allow it to dry before you actually insert it. If repalpation is necessary, I already mentioned it earlier, disinfect your clean gauze with the disinfectant. Sometimes if you're wearing powdered gloves, it may not work. So it is always better to wear the vinyl gloves which are not powdered. And there you disinfect. If you disinfect the gloves, again you have to wait till it is dry. Otherwise, you have to wear a sterile glove if you want to repalpate the vein. So now we have left the two C's and come to E. E is escalate. This is the most important part of this success framework. So when do I ask for help? So that is escalate. So seek assistance when there is less than two accessible sites. So even before you start poking the patient, examine the patient properly. If the patient has no veins at all, or even if there are veins, there are faint veins seen only in two sites in both the arms, then these are difficult IV access patients. Or no veins are visible or palpable, or if you have already attempted two attempts, then you have to give up. So this is when you have to escalate. Very important to remember this. And so I'm going to summarize now about the clinical pathway, though we have not covered the 2S, because I want to emphasize the escalation part of it. So far, what we have asked is the first question is, what is the solution I am going to give into the vein? Is it an irritant, or is it something which will cause vesicles and if it infiltrates? No? Is it hyperosmolar? Is it a highly concentrated solution? Does it contain chemicals which can necrose the skin? Or if the osmolality is greater than 600 milliosmoles per liter. So if like peripheral parenteral nutrition and many of these concentrated electrolytes. So if the answer is yes, then the patient requires a central venous access device. We don't put in peripheral venous catheter straight away. And if it is less than 3 months, you could put a PICC line. If it is more than 3 lines, then you need to put a tunneled catheter on implanted port. Okay, so it's very clear. So vesicant fluid, you deal with them totally in a different manner. So here we are talking about, that means it is a clear solution. It is not an irritant. Osmolality is normal, about 290 milliosmoles, which is the osmolarity of our plasma. And next question is asked us, is the peripheral access good? If the peripheral access is good, go ahead, put a peripheral IV cannula. If it's for 1 week. If it is between 1 to 4 weeks, you can either put a midline catheter or explain midline catheter is a peripheral cannula with about 10 to 15 centimeters length where the tip is near the axilla. Or you put a PICC line. If the peripheral access is not good, I told you, if there are only less than 2 visible veins, no veins, more than 2 failed attempts, it needs ultrasound peripheral IV cannulation. If you are an expert, go ahead. Otherwise, ask for expert guidance. So most of the time, if you ask for expert guidance, the expert also will come and put it blindly. That is the greatest tragedy in most of the hospitals. So we need to have workshops which train a certain group of individuals in every hospital on ultrasound IV cannulation. So that's very, very important training you have to have in each and every hospital. So success, now we have only the 2S remaining. Secure, skin should be dry after you put the IV line and the tapes are applied. You can either put a transparent IV dressing. Why should it be transparent? You can do your assessment of phlebitis using the VIP scale, visual inspection of phlebitis scale. Okay, so then you apply the dressing and you prevent the PVC hub and tapes. Very, very important. So most of the time you forget this step. Okay, so this is the point where the pressure injuries can happen. So you should make sure you should protect this part so that it doesn't press against the patient's skin and cause pressure injuries or increased pressure. Okay, so what is the appropriate dressing? So this is a protocol we use in our hospital. So I wanted to share with you, mainly in sort of reducing the expense to the patient. So we use non-transparent dressing, especially in the emergency, when the IV cannula is in situ for less than 24 to 48 hours. Many patients come to the ICU, emergency, where they need to have the line only for a short period of time, maybe for investigation, for rehydration. And if it's very difficult, most of the time it may not be very difficult to assess. This patient actually has a chance of going home. So these patients should have only a non-transparent dressing, which will cost maybe 30-40 rupees, as against a transparent dressing, which costs anywhere between 120, 150, 200 rupees for a dressing. So if it is in situ for more than 24 hours, we switch to. So, in our hospital, the ER puts the non-transparent dressing unless the patient is very sick and straight away going to the ICU or a trauma patient. And when the patient goes to the ward, the dressing is changed into a transparent dressing. So small things add up in reducing the cost to the patient. So we're coming to the last is sign and document. So you should actually put your signature on the dressing itself, put the date, and in the medical record, write the date, time, site where you have put, what is the cannula gauge, number of insertion attempts, who put in the cannula, how many resets. I think number of attempts and resets. That is, this we are talking up after the insertion. So every day you need to document. If the cannula has been resited, maybe to second day or third day, then you document that as well. and if it has been removed, the reason for removal, whether the therapy is finished or what is the reason you removed. And every shift you need to assess the visual inspection of phlebitis scale, score, and also document it. So this is the complete documentation for a patient who is on IV cannulation. As I said, on the IV cannula, date of insertion and the initial of those who did the procedure, or even in capital letters, so that people understand who put in the cannula. So, friends, in conclusion, the success framework bridges the technical skill. Now, we already have the technical skills, majority of us, but we also need to follow evidence-based practices. And I think the success formula is a very nice, compact acronym which bridges these two, evidence-based practice and the technique. And by adopting this, we will minimize errors, reduce complication, increase the insertion rate, and thereby improve patient satisfaction. So the take-home message is IV cannulation is just not inserting a needle. It is about ensuring safety, comfort, and proper follow-up and documentation. And please use the success framework. It provides a practical guide to minimize errors and optimize outcomes. Again, thank you so much. Lot of gratitude, and thanks for being with us this afternoon. See you next week, same time. Thank you.